Awesome. Hi, everyone. My name is Amy Austin. I'm the Behavioral Health Recovery and Community Supports Unit Supervisor here within HICPUF. And this is our webinar on billing Medicaid for health-related social needs supportive housing services. So thank you all so much for joining today. We're excited to be able to walk through some frequently asked questions that we've been getting from providers recently about billing for these services. And then we'll also have plenty of time for question and answer as well. So if you've recently joined, if you could put your name and what agency you're with into the chat, that would be great. We love being able to know who all is here today. So next slide, please. So here is our agenda for our meeting today. We're going to do an overview of the services that we're able to cover through our health-related social needs 1115 waiver amendment. Then we'll talk about some frequently asked questions that we've been getting from providers on a few different topics. We'll talk about member eligibility for the services, how providers can enroll with Medicaid to bill for these services, talk through some implementation questions as you all are, working through the daily work of how to operate and bill for these services. We'll talk about that. And then finally, some real specific questions around the actual billing process. And then we'll have plenty of time for Q&A as well. Great. Okay, we'll go ahead and get started. Next slide, please. So I want to get started with the timeline. Where have we been and where are we today? Because many of you have been with us through much of this process, which we're incredibly thankful for. So back in December 2022, we launched the statewide supportive housing expansion, or SWISHY, pilot project through funding made available by the American Rescue Plan Act, or ARPA. And so through that grant funding, we were able to facilitate a pilot project, which was really the first time that Medicaid in Colorado was able to partner really closely with the supportive housing community and look at what types of services are delivered and what Medicaid reimbursement could look like in that space. And so thanks to so many of you on this call today, we were able to serve over 700 members through that SWISHY pilot. And we also provided technical assistance to SWISHY grantees to help with that process of enrolling with Medicaid. So then when the SWISHY pilot ended, starting in October 2024 until the end of June of this year, we were able to cover some supportive housing services through our capitated behavioral health benefit. So we created that new provider type for supportive housing providers that many of you have already enrolled as or in the process of, and we consolidated the existing billable services into the per diem code and the per month code, really to make it easier for providers, that you all don't have to chase down, and map out multiple different service codes, but really can just package that whole, package of services into billing just a couple of different codes. So we were able to cover those supportive housing services through the behavioral health benefit. Services were billed to the RAISE through the end of June of this year. Excuse me. And now, starting July 1st, we have approval to cover an expanded set of services through our health-related social needs 1115 waiver amendment. So here in Colorado, we operate an 1115 waiver, which allows us to cover variety of services under Medicaid. Our 1115 waiver, kind of the bread and butter of where we started with that work, was being able to cover residential SUD services. And then we've amended that waiver over this past year to add a variety of other components. And so one of those waiver amendments is this health-related social needs work. So we were approved in January for that waiver, and then now this coverage has started in July. So lovely, exciting stars, but that is where we are. This has been a huge work in process, and really thank you all for the work that many of you did through the pilot with us to help us get the data and the understanding to be able to pursue this waiver in our state. So that's where we currently are. The waiver went live July 1st, and we're able to cover these supportive housing services that I'll talk about on the next slide. Oops, I got a little ahead of myself. So, questions about like what are we able to cover through this waiver? Why is this so exciting? Why did Colorado go through the work of adding this 1115 waiver amendment? So, like I said, we'll talk about the how we've expanded the services that we can cover under this waiver authority. We've also expanded the population that is eligible for these services. No longer is just limited to folks with the behavioral health need, like when we were covering these services under the behavioral health benefit, but we can now expand to cover folks with chronic health conditions as well. And finally, we have moved the reimbursement for these services to our fee-for-service billing. So it's no longer billed to the raise. These services are billed directly to Medicaid, and we'll talk about that in more detail as well. So next slide, what are the services that we can cover? So through our waiver approval, this is the list that we have gotten approval for CMS, approval from CMS to be able to cover, and we're going about implementing this with a phased approach. And so in our first phase, we are covering pre-tenancy and housing navigation services, pre-tenancy sustaining services for members. And so those first two bullet points on the green housing side are the services that supportive housing providers are able to bill directly to Medicaid for reimbursement. Then we're also phasing in being able to cover rent and temporary housing for up to 6 months. And then later we will be able to phase in covering one-time transition and moving costs. And those will be reimbursed through HECPF's partnership with DOLA. DOLA will actually be acting as a fiscal intermediary and paying per providers for those two second bullet points on that side. What's really exciting about this waiver work is that we're able to draw down federal dollars to be able to match the state dollars going into this program and really be able to expand the resources that we have in our state for covering these services. Then we also have approval from CMS to phase in some nutrition services. And so we're currently still in the research stage of what this implementation will look like. And at the very end of the call today, we're going to share with you a survey link that our nutrition team would love your feedback on to really understand the current state of how nutrition services are being utilized within the supportive housing space. And that will help them as they're developing, rolling out that side of the benefit. Okay, next slide. Awesome. Okay. I do want to take questions as we go. So any questions so far about the service package that we are able to cover? And we'll have time at the end as well for questions, but maybe I'll kind of pause at each chunk to see if there are any questions in relation to that content. Okay, I'm not seeing any hands raised, and I'm going to ask my colleagues to help keep an eye on the chat as well so that we can pause if needed. Okay, great. So our first chunk of FAQs to go through are questions about member eligibility for these services. So next slide, please. Okay, so at a high level, what are the populations that are eligible for the health-related social needs services? So 3 populations eligible for housing vouchers here in Colorado are eligible to receive these services. Today, we're going to talk specifically about individuals eligible for permanent supportive housing, since that is the provider network that we are presenting to today. But if you know of folks or your agency is interested in serving these other populations, definitely reach out to us and we can connect you with our colleagues who are managing those components of this benefit. So let's go ahead and dive in. So, what is the eligibility criteria for these services at a member level? So, in our commitment to CMS, we say that individuals must be eligible for Medicaid and then must meet social and clinical criteria. The social criteria matches the definition for permanent supportive housing eligibility here in the state. And then, if we go into the next slide about clinical criteria, we have talked about, I know I've talked with many of you all previously, but this is our clinical criteria about behavioral health needs and chronic health conditions. Yep, all of this information is also published on our website so that you can really go back and look at this in detail. But at a high level, for members to be eligible to receive these ongoing services, at some point they do need to have a clinical diagnosis for either a behavioral health need or a chronic health condition that falls into our definition that was approved by CMS here. Okay, next slide, please. Then we have the PSH population broken up into 3 different population groups. And the reason we do this is because folks, depending on how long they've been involved in PSH, may be eligible for a different set of services. And so PSHA population are folks that are newly matched to a PSH voucher within the past 12 months. The PSHB population are individuals who are eligible for PSH but not yet matched to a voucher. So we know that's the largest population here in Colorado, folks that have been deemed eligible by HMIS but are not yet matched to one of the vouchers here in the state. And then population C are individuals who have resided in permanent supportive housing for more than 1 year. So on the next slide, we map out this population, these different populations to the eligible services. So population A, folks who are recently matched to a voucher within the past 12 months are eligible for the whole extent of services that we can cover for housing under the waiver. PSHB, folks are eligible for those pre-tenancy supports and targeted case management to help them, prepare for being able to move into housing. And then population C, folks residing in PSH for more than 1 year are eligible for the ongoing tenancy sustaining services and the targeted case management supports. Awesome. Okay, any questions about member eligibility? Okay, I'm not seeing, I do see a hand raised. Yeah, Heather, go ahead.
Yes. So, what about those clients who are in long-term PSH, but then they need to relocate? Does this also cover moving costs? Does this cover, anything in between that? Because I don't see that as like readjusting into a new home.
Excellent question. That is the first time I've thought about this. So I'm gonna have Carlos Anderson, who's on my team, write that down. And we will loop back to see if there may be any allowance for that particular scenario. That's a great
Okay.
question.
Thank you.
And then Robin,
Yeah, I'm curious for people that have a physical health condition, does that mean then for the ongoing supervision, it would have to be like a physician or a medical person that oversees all the billing?
excellent question. And I do have some slides dedicated to supervision in the implementation section. Is it okay if we wait until we get to that point? Because we
Yes.
can definitely talk through that.
Yeah, that's fine.
Awesome. Any other questions about member eligibility? Okay, I'm not seeing any more, so we'll go ahead and talk through the provider enrollment FAQs. So the first slide, I want to do some level setting. So we have a lot of terms within Medicaid. So really want to talk about the 3 different types of providers that we think about and refer to within this landscape. So at the highest level, we talk about Medicaid billing providers, and this is either the agency level Or sometimes in other scenarios, there are independent practitioners, like a licensed clinical therapist or social worker, who would enroll as an individual provider and then have a direct relationship with billing Medicaid. So at the highest level is the Medicaid billing provider. That agency in this context has a billing provider NPI, and that NPI goes on the claim form in that line for billing provider. Here within supportive housing, it's a group provider enrollment, and that's the billing provider level. The next level of a provider is a rendering provider, and that's the licensed clinician who's responsible for oversight of the services delivered to a member and whose NPI number is put on the claim. And that's what Robin was referring to, the clinician that does supervision. And that individual must also be enrolled with Medicaid, but they are put on the claim as the rendering provider. And then the next level is an individual service provider. And the service provider is the individual who's directly delivering care to a member. And in some cases, that individual may be a licensed clinician who is enrolled with Medicaid. But in this context, it's often unlicensed professionals who are not an enrolled provider, but are delivering services under the supervision of the rendering provider. Next slide. Okay, so at the billing provider level, what's the provider type that can bill for these HRSN supportive housing services that we're talking about today? And that is limited strictly to our supportive housing provider type 89 with the specialty code 208 is our supportive housing provider type. We are also exploring opportunities for how we can support federally qualified health centers or FQHCs to operate in this space. And so if your organization is a federally qualified health center, please do reach out to us so that we can navigate what that looks like with you. But kind of with that exception aside, all other agencies are asked to enroll as this new supportive housing provider type to be able to bill for these services. Okay, what are the requirements? How does an organization go about enrolling as this provider type? So requirements are that an agency must manage and provide services to an allocation of permanent supportive housing vouchers and be approved as a supportive housing provider by DOLA's Division of Housing. And so a first step is to submit a request form to get an approval letter from DOLA. And if anyone needs that link, you can raise your hand or request it in the chat and we can drop that link for you. But it's that approval letter is needed to fill out the provider enrollment application with Medicaid. So it's in place of, and other types of providers may require like a facility license. Since we're working in the housing space, DOLA is the entity that is overseeing that approval process. So an organization gets an approval letter from DOLA, also needs to obtain a national provider identification or NPI number. That is through the national NPPES system. And then an organization must also ensure that you either employ or contract with a licensed clinician who will affiliate with the group enrollment and serve in that role of the rendering provider to supervise any unlicensed professionals delivering services. And then finally, to have all your requirements in place, there's the process of actually enrolling with Medicaid through the provider portal. And our team is here to help answer questions and help you navigate that process. So if you haven't started this yet and you're ready to get started, please do reach out to us via our housing supports email. Carlos, I'll have you drop that in the chat. And we're happy to help organizations navigate this enrollment process. Okay, next slide. Okay, Another question providers may have, why do we need a licensed clinician to affiliate with the group enrollment? And that's like I've talked about already, that direct care services who are provided by individuals who are unlicensed need to be supervised by a Medicaid enrolled provider who is the rendering provider. And then the rendering provider puts their NPI on the claim form. So a supportive housing provider may have one or may have multiple licensed clinicians affiliate with the group enrollment. And we'll go through, I think we have some slides. So we might have that slide next. Let's take a look. How do we actually affiliate with the group enrollment? Here we go. So within the provider portal, there is a section on the left-hand side to click on provider affiliation changes, and then you can click on add, and that is where you can add the NPI number for that licensed clinician. And actually, this is the process to formally affiliate that individual provider with your group enrollment. So that individual provider needs to have their own NPI, needs to be enrolled independently with Medicaid, and then you're able to have them affiliate with your group enrollment. Any questions about this? Okay. Next bit is about can organizations have multiple provider types with Medicaid? The answer is yes. Organizations may enroll as multiple provider types as long as the organization meets the qualifications for each. So we know many supportive housing agencies may also already be enrolled with Medicaid as a behavioral health group or another type of provider. And so, yes, you can have multiple provider types. Just a separate NPI number is required for each of those enrollments. Next slide. Already answered this one. Yes, you need a distinct NPI number for every service location where staff have their offices, and then a separate NPI number for each provider type enrollment as well. Okay, any questions about provider enrollment? Many of your agencies may already be well through this process, which we're super thankful for. If your agency is just starting this or is interested in learning more, please do reach out. We're happy to help with that provider enrollment process as much as we can. Okay, I think this is what folks are excited about talking through today, potentially the most, our implementation FAQs. So let's go ahead and dive into this. So we have talked about this for a while. What are the requirements for staff delivering these health-related supportive housing services? Um, Exciting news. We have been able to get quite a bit of feedback from our provider community regarding the staff that you have employed currently that are doing these amazing services for providers. And over the past couple of years, we've heard concerns that not all of those staff meet the bachelor's level requirement or may be trained as a peer support professional. And so we've gotten a lot of questions around like, are there opportunities to expand these requirements to be able to include different types of unlicensed staff? So we have some language that is in the approval process for rule here in Colorado. So rule is one mechanism that governs Medicaid benefits here in Colorado. And so if this rule is approved as it is currently drafted, these will be the new requirements. So staff delivering supportive housing services under the benefit must either have a bachelor's degree or have at least 3 years of relevant experience appropriate to the requirements of the position. And so that would be the responsibility of the provider to establish what that means for your organization. And then in addition, staff must also be trained in a variety of areas that are integral to this work. So such as social, cultural, educational, and economic factors that affect the members that are being served, must be trained in person-centered planning, interpersonal communication skills, crisis intervention, and then must also, be trained within relevant policies and procedures related to this as well. And so we will communicate to our provider network as soon as this rule is adopted. But I'm very excited that we're able to hopefully being able to expand as well. And then question about will the other credentials still be eligible? Yes, we will share the list that was previously eligible under the behavioral health benefit, which is like the peer specialist, qualified behavioral health assistant, etc. Those identified professional types of professionals will also be able to deliver these services, and then we'll also have this expanded definition as well. Okay, next slide. Okay, what are the requirements regarding supervision? So Robin, here we can talk about your question. So all unlicensed professionals must be supervised by a licensed clinician that is affiliated with the group and listed on the claim as the rendering provider. And so the clinician that's affiliated with your organization is responsible for supervising the services that are delivered within your organization. So they're responsible for supervising those pre-tenancy, tenancy sustaining services, and targeted case management supports. An individual may qualify for these services, like we said, with either behavioral health need or a chronic health condition. And those clinical needs are likely going to be managed by a clinical provider outside of your organization. And so you're able to get that documentation regarding the diagnosis via a referral. And then the licensed clinician within your organization is only responsible for supervising the services delivered within your supportive housing organization. So, Robin, does that make sense? You may not be engaging in that clinical treatment plan for someone with a chronic health condition, but your staff may be, doing that work to help connect a member to a primary care provider, helping them get set up with specialist appointments, those types of things, but not responsible for overseeing the clinical care of that member.
Yeah, that makes sense. So the treatment plan associated with that client would then be from the medical provider, and we would just be overseeing the like case management services.
Yep, that's correct. Yeah, the member's medical clinical treatment plan would be something managed by their referring clinical provider. And then within your organization, you'd be responsible for a care plan or housing stability plan, however your organization wants to define that. And that pertains to the non-clinical supportive services that are covered by this waiver authority. Does anyone else have follow-up questions regarding that? And then I see a question about, will you provide specific examples of the types of training and places to obtain it? I think that is, we can go back to the previous slide about this type of training requirements. This is really up to each agency to develop your policies and procedures around how to meet these high-level training requirements for your staff. Okay, let's continue. Okay, next question that we've been getting is, how does the supportive housing provider verify that a member meets the clinical criteria for the health-related social needs services? So the clinical criteria are initially determined to be met through self-disclosure by a member of a behavioral health need or a chronic health condition through the HMIS coordinated entry referral process. So if your organization receives a form through the HMIS process that is documentation of a disabling condition for that member, that would be sufficient to say, yes, we have reason to believe that this member meets the definition of a behavioral health need or a chronic health condition as required by CMS for these services, and therefore you're able to begin delivering and billing for those services. And then part of that work, of working with that member, delivering the non-clinical supportive housing services, is helping them look at the whole picture of their needs, and understanding if there are needs to refer to clinical services. And so each supportive housing provider should establish policies and procedures regarding how you'll do that work of confirming that they do have an eligible diagnosis to keep on file by your agency. So that can often look like helping refer them to a medical provider, and then obtaining that documentation through a release of information. And so, again, we really want these services to be low barrier, recognize that there's opportunity to get started working with someone through that self-disclosure of meeting that clinical criteria. And then it's really up to your agency to say, okay, this is going to be our process where eventually we're going to work with that member to confirm that they do have an eligible diagnosis to keep on file for your agency. I think I see a question in the chat. Does this need to be updated with any frequency? There is not directive from Medicaid regarding that, but again, that would be the responsibility of your agency to establish policies and procedures to really think about best practice and what that should look like for the best care of the members that you serve. Awesome. Next slide, please. Okay. Any questions on the member eligibility section? Okay, then we'll go ahead and talk about billing and frequently asked questions in this space. Okay, so first question is, what are the billing codes that providers can use to bill for the health-related social needs supportive housing services? So I have all of the codes here on this table, and I want to walk you through each of these with the modifiers, because this use of modifiers is new for dates of service starting July 1st. As covered by the 1115 waiver and billed fee for service. So all of this content is also published on our website. If you need a refresher, please visit it there. But wanted to really take the time to talk through this today with this provider group, and then we'll post this content on our webpage for future reference as well. So the first code I'll talk about is targeted case management for housing supports. That is code T1017. This is a new code that is eligible to be billed by supportive housing providers now that we have coverage by the waiver. Yeah, I'll talk in the next slide kind of more detail about how that is utilized. But want to call out that the code is T1017 and the position 1 modifier that you'll put on the claim form is U2. And you'll see that for all of the codes that your organization will be billing, you'll use that position 1 modifier of U2. And that modifier indicates to HECPUF that that service is being delivered to a member within the permanent supportive housing or PSH population. And so at the beginning, we talked about we are able to cover services for 3 different populations of voucher eligible individuals. And so to be able to sort our data between those 3 populations, we're using the first position modifier. And so PSH services will be delivered using that U2 first position modifier. Okay, so the next codes that we'll talk about are the supportive housing per diem and supportive housing per month codes, H0043 for per diem and then H0044 for per month. And then those codes are distinguished with the use of a second position modifier to indicate whether it is a pre-tenancy service being delivered to a member or a tenancy sustaining service being delivered to a member. So if it is pre-tenancy, you'll use this position 2 modifier UA. And then if it's tenancy sustaining, you'll use the position 2 modifier UB. So next slide, please. This is again just to reiterate why we are using modifiers. Position 1 modifier, U2, indicates the member is within the PSH population. And then position 2 modifiers differentiate between pre-tenancy and tenancy sustaining services. And this really supports our reporting to CMS, the Federal Centers for Medicaid and Medicare, since they want that differentiation within our data. So next slide. When do we switch between using the pre-tenancy modifier and the tenancy sustaining modifier? We are telling providers that if you are using the per month code, please use the position 1 modifier to indicate pre-tenancy services up to and including the month in which a member moves into their unit. If you are billing using the per diem code, then the day that the member moves into their unit is the first day that you should begin using the position 2 modifier UB to indicate the delivery of tenancy sustaining services. Any questions on that? If we can go a slide back or 2 slides back. I want to point out that we are not asking for a position 2 modifier on the targeted case management. It's the supportive housing per diem and per month codes that we want to be able to differentiate between pre-tenancy and tenancy sustaining services. So yeah, if anyone has questions on that, I do see a hand raised by Sarah. Go ahead.
Hi, thank you. I just had a question because I try to think ahead of time on what I could experience. What if we had somebody who technically made the H0044 monthly volume, but they're kind of in between pre-tenancy and tenancy for that month?
Great question. Let's jump a couple slides. Yep, this one. So in order to be like the most just clear and everyone agrees to the same process, it's this first bullet point that we're
Okay.
saying, please use pre-tenancy up to, and then also including that month that someone moves into their unit. So today is July 24th. If someone moved in today, you would bill at the end of July, for that full month of July with the position 1 modifier for pre-tenancy. We're also saying if someone moved in on the 1st of July, just so we're all like, using the same approach, you would still bill that month using the position 1 UA modifier for pre-tenancy services, just so that we're like consistent across the board. Does that answer your question?
Yes, thank you so much for going back to that.
Yeah, absolutely. We didn't want it to be weird of like, is it in the first half of the month or the second? We figured it's easiest just say, if they moved anytime in that month, bill that month as pre-tenancy support. Awesome. Okay, let's continue. Okay, what are the time requirements and the rates for the different codes? So now that we are operating within the fee-for-service model, we do have a published fee schedule. And so these are the exact rates that providers will be reimbursed for these services. So T1017 targeted case management, 1 unit of that code is 15 minutes. And so providers are able to bill for up to 4 units per member per day. So that's 1 hour of targeted case management, maximum in a day. And then that maxes out at billing 8 units or 2 hours per month. And those services can be billed in addition to the supportive housing per diem or per month codes. And targeted case management is really intended to be used for those times that you're doing work on behalf of a member or working on referring them to services. We have a definition of targeted case management on our website that I would encourage you all to reference. And then we'll be continuing to flesh out our website with full definitions for each of these services as well. So that's targeted case management. Then supportive housing per diem. The member does not need to be present for targeted case management. That is in the state definition in rule for targeted case management, that they don't need to be present. That work can be done on behalf of a member. Okay, and then supportive housing per diem. The way this rate was calculated and set by HCPF is to reimburse for services delivered in duration of 2 hours or more for a member in a day. I know we've been getting a lot of feedback that doesn't necessarily match up with the model of how supportive housing providers are delivering services with a member-centered approach. We are taking in that feedback. We really appreciate these conversations. Please know that this is quite a lengthy process to go about identifying a different code, setting a new rate, and making adjustments. But that is something that our team is exploring, and we will be able to share more information as we get farther along into that process. But for now, the rate is set to reimburse providers for 2 hours or more of services delivered to a member in a day. So really encourage you to think about, combining things as you're working with a member. Think about different types of staff that may be engaging with a member on the same day. They could participate in a group. They could work with a peer support professional. They could meet with their case manager. Like there's a variety of different types of services or different professionals that could work with a member on a given day to add up to that threshold of 2 hours of services. Let's see, I think I saw a hand. Did I see a hand or did I see a chat? Oh, Heather, yeah, go ahead.
Yeah, so okay, so just wanted to get an understanding. So if someone, so the 2 hours or more, that we can be spending like 5 hours with a client, and that can be on like let's say an outing, right? Oh, am I understanding that even with those 5 hours, we would still be only receiving $54.63?
So because it's a per diem code, that is the rate that is reimbursed for a day of services. And it needs to be at least 2 hours. If you're delivering 5 hours of service to a member, maybe that's at the time that they're, getting close to leasing up and there's a lot of work going into it. If you expect that you may hit 15 hours or more in that month, it may be a good idea to wait to submit claims until the end of the month to see if you meet that 15-hour threshold, and then you could bill for the per month code. Does that answer your question?
Yeah, thank you.
Yeah. And oops, I hit the wrong button. I'm gonna look at the chat. Can travel time be counted? So travel time can absolutely be included in the time that is spent as long as there is a service component, like a skill building or therapeutic aspect of that time. So if you're just driving someone around like an Uber driver and there's no conversation happening, that wouldn't necessarily meet the definition of these services. But for example, if you're, picking up a member from an appointment, debriefing, talking about next steps, then that time would certainly meet the definition of the services being provided. 2 hour limit for case management per month. For the targeted case management code, T1017, yes, there is a limit of billing 8 units per member per month for that code. And that is in addition to being able to bill for either the per diem code or the per month code for supportive housing services. Any other questions about this?
Yes, I had one real quick. Just to confirm that then the limit of per diem billables each month would be 14. And once it hits 15, we would bill them monthly. But we could bill up to 14 per diems each month.
Since the per diem is built on 2 hours of service for a member, then it is maxed at 7 units of that per diem, because 2 hours times 7 units would be 14 hours of service delivery. And so if it's 15 hours or more of service delivery, then you can bill the per month code.
Okay.
Yeah, good question. So yes, this the H0043 has a maximum like a limit of billing up to 7 units per member per month for the H0043 per diem code. Okay, awesome. Next slide, please. How are and Heidi, you got to answer, or you got to ask your question, right? I still see your hand up. I just want to make sure. Yeah, okay, great. Okay, next question is how are claims billed for these HRSN supportive housing services? So for dates of service beginning July 1st, these services are billed through the fee for service billing method, which means they are submitted directly to HCPF via the provider portal. Next slide, please. Okay, I see Carol raised a hand. Go ahead.
Thanks, Amy. Hey, I'm sorry, but can you go back to that slide that had that? Yes. When would you code for targeted case management T1017 versus the H0043? Is it just a matter like if you do less than 2 hours in a day for a client, that's when you would do T1017?
Good question. I'm going to pull up our webpage because we do have a definition here of targeted case management, and it does have a little bit of a different definition than our supportive housing codes. And we are working on getting more content on our website so that we can have like a robust definition of each of these supportive housing codes as well. But targeted case management involved linking the member to the direct delivery of services, but it is not the delivery of services itself. So, for example, referrals and care coordination work. So, like connecting a member with a food bank or helping them set up medical appointments, like those types of activities when you're helping coordinate care for a member, whereas the supportive housing codes are more about the direct delivery of a service itself. So life skills, conflict resolution, working, with someone to actually like fill out a lease application, like those types of things would fall
Okay.
under the supportive housing codes. And like I said, we're working on getting kind of those additional examples published on the website. But targeted case management has a real specific definition about linking a member to services.
Okay, thanks, Amy.
Yeah, you're welcome. And then I see Heather's hand raised.
Hi, this is actually Beth. But my question is, if we bill for the per diem and you do your 2 hours with someone, but what if in the same day they're having a life skills class with a case manager or a budgeting class? Can you do that as a separate code in the, the big code book?
They would still be supporters.
Um, what I think your question, thank you for your question. And what I think you are referring to is, can a member receive like behavioral health or clinical services at this on the same day as receiving these health-related social needs supportive housing services? So
Yes.
yes, if your organization is enrolled as a behavioral health provider, you can bill for services that are covered under the capitated behavioral health benefit, as long as that member is eligible and meets the requirements of that service.
Okay.
Well, so wait, one other question. Does it would still have to fall under the MPI for that specific program though, right? Or can it be a different MPI? Well, because that MPI would have to go to the clinic, you know what I'm saying? If a clinic was providing services, we wouldn't get that funding. You know what I'm saying?
Hmm.
Like if I were to provide clinical services, then I can potentially bill a different code for clinical services.
Yeah.
Okay, sorry, you didn't need to hear
Thank
that.
you.
Thank you.
Yeah, that's a good call out. Like, your organization may have multiple Medicaid enrollments. And so you would want to really track which enrollment you're using to bill for those services. Yeah, that's a good. I see the gears turning. That's a good thing to think about for providers who are maybe working as multiple different types of Medicaid providers for a member. Awesome. Let's see. Has the description of H0043 and 44 been changed to no longer include case management? So case management is kind of a broad term. And it's important to really kind of like look at exactly what activities you are considering within that term of case management. So targeted case management has a real specific definition that we do have published on the website about helping refer a member to services or doing work on their behalf. And then we recognize there are some kind of like broad case management work that is maybe the term you're using to refer to housing navigation services and checking in about someone's care plan. Those types of activities are definitely covered under the supportive housing per diem and per month codes. And like I said, we're working on getting some of that language finalized so that we can publish that on the website to have a more robust definition for each of those services. When we did cover these services under the capitated behavioral health benefit, if you were working with us at that time, you'll remember we had a couple of coding pages for H0043 and 44 in our state behavioral health services billing manual. Because those services are no longer covered under the behavioral health benefit, we have removed those coding pages from the billing manual. And then since there's less of a cohesive billing manual on the fee-for-service side, we're going to be publishing that equivalent information on our webpage so that you can have kind of that information that you're used to seeing on the coding page that has the example types of activities, the allowable place of service codes, all of that information will be posted on our website pretty soon. Um, let's see. Our organization is provider type 64, which is an SUD provider, and then we're now also enrolled as provider type 89 for the supportive housing provider. Could our supportive housing program be listed as both 89 and 64? So your organization may be working in multiple spaces within HCPF as different provider types, but then different provider types are eligible to bill for certain scopes of services. And so these supportive housing service codes that we have pulled up here are only able to be billed by the supportive housing provider type 89, specialty code 208. And then any clinical services that your organization may be delivering would be billed through your provider type enrollment as a clinical provider type. Does that answer your question? And Homeward Pikes Peak, we can talk more offline if you want to talk through any more specifics on that. Yeah, Michelle, go ahead.
So with like behavioral health, with therapy right now, when we bill $105, we actually receive, sometimes closer to $95. Are we going to be receiving the same amount that we're billing that's listed here, or is it going to be a lesser amount?
I'm not familiar with what you're referencing about how much you're reimbursed by the raise. But these are the published rates on the fee-for-service fee schedule
Okay.
for these benefits.
Okay.
Yep. Okay, let's keep going. I know we're getting close to time. I do have time to stay longer if anyone wants to, but want to respect your time and at least get through the content that we have prepared. Next slide. Awesome. Okay, I'm going to hand this over to my colleague Carlos Anderson, who's going to give you just a real quick high level overview of what this system looks like to actually submit claims through fee-for-service. So Carlos, take it away.
Yeah, hi folks. So if you've been through the billing training that we had folks go to last week, you might have been familiar with some of the stuff we're going to talk about. If you've never seen this before, don't worry. You won't see this screen until you're enrolled provider. But just to give you a visual of what it would be like to submit a professional claim through the provider portal, you log into the provider web portal. It will take you to this page. You can navigate towards the top using the tabs, navigate to the claims tab, and it'll take you to the next slide. The claim slide, you're going to want to submit your professional claim by selecting submit claim prof there in the red rectangle, and it'll populate a claim form. The red rectangles on this form are just to give you an idea of where the procedure code, the place of service code, and the modifiers will go on that claim form. There's a bunch of different information that will go on these forms. It's going to depend on the kind of service that you guys are giving, but I wanted to give you a visual representation of what that would look like once you're enrolled and once you're submitting claims. Does anyone have any questions about that?
Awesome. Next slide, please.
And also, just so you guys know, if there's issues that if you come up with anything to do with the provider portal, you can always access the provider services call center, and I can provide all of these web pages for you in the chat as well. If the call center is unable to resolve your issue, you can reach out to your provider relations field representative at this website. For training on how to use the fee-for-service system, please visit the provider training webpage if you want to learn more about it. As some of us have probably already attended the fee-for-service billing that was given last week. And then also for resources on web portal end user information, please see the portal end user quick guides webpage. And it gives you a list of different troubleshooting guides for how to get through the web portal. And of course, once again, always you can always reach out to HICPUF Housing Supports, the email, and I know we're almost at time, so I'll go ahead and give it back to you, Amy.
Awesome. Thanks, Carlos. And I do believe that content from the billing training that the department facilitates is posted on that provider training webpage. So if you're unable to participate in one of the facilitated trainings, I believe they're offered monthly. You can access the published content on that webpage. And so as a reminder, you'll look for, and I can show you where this webpage is really quick. There's a calendar with the training schedule, and you can click and sign up for Zoom for any of the trainings. And then you'll want to look at content for professional claims. This CMS 1500 claim is the claim form that is used to bill for these supportive housing services. Okay, we did it. Any additional questions for our team? Thank you all so much for joining today. I'm going to pause the recording.